Services. And for this lecture, may I invite Dr. Vani, and everybody knows him. He is the brain behind this workshop. So, Vani, it's over to you.
Slido.com, and the code will come up as we go by. So we have looked at a lot of things over the last 2 days, and we are and you may be wondering, you caught up several things about ILD, but when you go back, how do you put this in practice? So many aspects have been touched upon. So, you need to have good diagnostic facilities to be able to diagnose ILD in a very precise manner to offer the right treatment. You have to have the support of a multidisciplinary team, because just a pulmonologist, you can do only that much. You need to have an ILD clinic, because, that is where more focused treatment. When I see a patient in my regular OPD and ILD clinic, it's very different. You have a lot more time, there is a lot more focus and intensity, and you can have more paraphernalia staff who can contribute to the betterment of the overall care of the patient. So I think that's something that we need to work on. And the education of the patient, as Dr. Jennifer also alluded to, is very important for a complex disease like ILD, where even we do not understand many things. And then ILD MDT is kind of the backbone which we all talking about, so that's what I will focus on in this talk. And rehab, palliative care, patient support, end-of-life care, all these are important, but it's been dealt with at various points of the last 2 days. So I'm going to focus on how do you have an effective ILD MDT, what's the role of it, and how do you set it up and how do you run it. Now, this is going to be very different based on what setup you're working. I'm going to project something that is more ideal, and what works like at larger tertiary institutions like ours. You may have to tailor it to your own work circumstances. So we look at what is an ILD MDT, evolution of the concept in the literature, who should be the members, what is the role of it, how to set it up, run it consistently, and a few words on our experience from CMC. It's actually called ILD MDT, where it's a multidisciplinary team discussion, and it is something that discusses the following things with regards to a patient who is suspected to have ILD. It helps in the diagnostic pathway and coming to a diagnosis. It helps in deciding treatment options, and in certain situations we use it a lot for ambiguous situations in follow-up as well, where there is lack of data globally, but I'll share what we have experienced over the last 6 years when we formally started our structural ILD MDT. So the first question is a formal ILD MDT needed? In the current scenario of ILD in our country, in your situation, should we have a formal ILD MDT, or is just, pulmonologist taking the phone, calling the radiologist and deciding? In a lot of places that is the most feasible kind of MDT, but is a more formal, structured MDT needed? So among all those who have answered now, I'm very thankful that everyone agrees that a formal ILD MDT is needed. So then you have to really, work around your situation to see how you can get that done. It's not easy. So if you look at the literature, right from the 2001 ATS ERS guideline is when first the word multidisciplinary consensus is used, and subsequently multidisciplinary inter-observer agreement in the diagnosis of IPF, multidisciplinary team meeting, and its impact on the diagnosis of DPLD. The first paper came in Lancet in 2016. And then subsequently there have been from various countries in large numbers, larger MDTs have been few in number. I'll come to that. Now the next question before we move forward is, who all do you think should be a member or part of the ILD MDT? There are numerous options and you can choose multiple answers for this question, not just one answer. Okay, all of you agree that there should be a pulmonologist, radiologist and rheumatologist, and 88% pathologist, 75% palliative care physician. Wow, probably the impact of Dr. Jennifer's talk is quite recent. Physiotherapist, 45%, go down. Okay, I'm not able to see the ones below. The respiratory therapist, and there are a few others below, so I don't know how many of you have scored that. Okay, nevertheless, I think pulmonologist and radiologist is the bare minimum that's required, and often that is what you need in a substantial amount of cases. Yes, where you've done a biopsy, a pathologist input, where there is rheumatological dilemma, rheumatologist, and there are a lot of miscellaneous individuals who could play a role when your MDT grows to provide more comprehensive care. But one thing I would like to stress on is that the pulmonologist who's in the team should be a ILD focused pulmonologist. Now that makes a lot of difference how the outcome of your MDT in terms of diagnosis and treatment is being decided. So each of you, if you endeavor to be a ILD focused pulmonologist, then you need to go that way to be able to bring out meaningful outcomes from your MDT. Now, the role of the MDT is in diagnosis, in prognosis, in follow-up and progression, in deciding treatment, and in today's world also to decide lung transplant referral. One point on Vimi's talk, in our country, if we start referring everyone with a diagnosis of IPF from FEC of less than 80%, then I don't think the transplant physicians in our country can handle it. So we have to have different strategies for our country, and a lot of cogs will come in the wheel to decide that. Those are from the Western population, where the transplant centers are independent centers, and unless the pulmonologist center refers to the transplant center early, they've had instances where patients reaches beyond the goalpost and nothing can be done. So to avoid that referral is early, I think in our country with a huge mismatch of number of ILD patients to transplant, we have to very judiciously look at when we should refer. There are about 7 large publications, and there is one systematic review, so I'll just focus on that before we move forward. So this was published in 2019 in Frontiers. It looked at 29 studies which have reported ILD, MDT, and how and its impact on the management of ILD. It confirmed the diagnosis in 54 to 80%, suggested the diagnosis 20%, which means there were further things to be done before diagnosis could be made. And from unclassified ILD, it became a very clear diagnosis after the MDT in 71%. Only 2 studies have reported prognostic outcomes of an ILD MDT. Absolutely no data on treatment follow-up and how in follow-up the ILD MDT could, on treatment there is no data, meaning diagnosis is there. What treatment was decided at the ILD MDT is not available. Follow-up, there are 2 studies and which also report 11% change in the diagnosis over time while on treatment with ILD. This report in respirology captures the fact that MDT can be useful in several points during the diagnosis. After the initial workup of history examination, initial bloods, pulmonary function, and HRCT, sometimes a patient may go through a MDT, then be suggested to do BAL, then we'll go back to the MDT, then a biopsy is done, then go back to the MDT before diagnosis is done. So some patient may require, most patients will require just one discussion in the MDT, and many may require 2, but beyond that could be quite rare. Now, how to set it up? We need to form a group of interested, focused individuals who are committed as well. And then you need to decide on the frequency of meetings. If your number of ILD patients you're seeing are less in number, then it can be ad hoc. If you have a sizable number, then you need to make it at a regular frequency, once a week or twice a week. It could be face-to-face or virtual. And you have to prepare a format of the presentation of how the data is going to be presented and the outcome comes. Otherwise, it may take a lot of time and may lose focus. How to run it consistently? MDT should not get stopped by anything once it's scheduled. Like we run our MDTs every Wednesday and Saturday. Today we have this workshop. It has been blocked and rescheduled for Monday. So it just happens twice a week, regardless of who is there and what happens. So that only then you can ensure there is consistency in running the MDT. Have a group of specialists, more than one in each specialty in rotation. Otherwise, when the pathologist is on leave, you won't have that input. So there should be more than one per specialty. And you have to keep it interactive. There are, in our MDT, we have different levels of pulmonologists. There is a junior pulmonologist, there is an anchor pulmonologist, and a senior pulmonologist. So there is opportunity given for the juniors to slowly grade up in their level, and inputs are given where required by the senior person, so that there is a process of learning and interaction, and there is so much learning that happens during that time. And we sometimes try to give feedback about a patient. We discussed last MDT. This is what happened after the MDT. That keeps particularly the radiologists going. Otherwise, they get only a very cross-sectional view and may not have the motivation to continue. So for best outcomes, we should have a very thorough discussion, and the pulmonologist should be the leader to put it together. And then a consensus is important, and when in doubt, we have sometimes reconvened for that particular patient with additional info to decide. And then scribing is very important. So we have two of our registrars who are scribing, and that is checked by the junior consultant who's on the MDT, and we ensure that the correct information goes back for management. Otherwise, there can be miscommunication in many of these areas. And sometimes it is true that the MDT has brought out some output, but the right information was not fed in at the MDT, so the output was not all right. So when as a physician we see back the patient and the MDT output is not matching, we rediscuss to come to a conclusion. So that also is a small practical point that we noted. So just few words on our experience. We are 2 to 3 pulmonologists with at least one with ILD specialist interest who's on an MDT, and a radiologist, always rheumatology, pathology as and when needed. Wednesday and Saturday we spend around 2 hours, 20 to 25 patients are discussed every MDT, which is about 50 a week. And 40% of them are 40 to 50% are new, another 40 to 50% are repeat with decisions which are ambiguous, which is run. And we run it through MS Teams. We actually started in 2018 face-to-face. Because of COVID, it went MS Teams, and we are continuing the same way virtually. And there is a lot of benefit in that, because when one person is seeing one, we are able to go to the details of that patient and give additional input where needed. So it's probably gone for the better because of COVID. So we have a facility by which either from the ward or outpatient, the physician posts into the MDT on the clinical workstation. Now that is visible by the radiologist who prepares for the MDT, and one of our registrars who prepares one slide per patient for the MDT by the previous day. And that morning the PowerPoint is shared to the group as well as presented during the MDT, and then the radiologist reviews the images, pathologists, rheumatologists come in where required, and the pulmonologist concludes the diagnosis and plan, and this once finalized by the registrar scribing and the junior consultants get scribed back onto the workstation. Now it's available as a record lifelong kind of, and when the treating physician who may not have been part of the MDT sees back the patient in OPD or the ward consultant in the IP, they take that and follow the instructions. So this is how our workstation work. I've hit the patient details. So actually this is from this week. I'm showing the 23rd list. This is scroll down, there were about 22 patients discussed on 23rd. And today is 26, so we have blocked it and we moved it to 28. So 28 MDT is open, and the patient is posted, and this is the posting details. and once we manage the conference, the opinion is posted here, and when the patient sees back in OPD, the doctor seeing the patient is able to look at the opinion, and that gets onto the EMR and translated to real practice. So next few minutes, we looked at the impact of our MDT on ILD over a period of 6 months. So in that 6 months, we had discussed 522 patients, out of which 60% were new patients and 40% were follow-up patients. In the new patients, we looked at how the diagnosis had changed from what the initial physician diagnosis, and in the follow-up patients, we looked at how the treatment plan had been modified or changed. So this is on diagnosis. We saw that there was an impact of the MDT on the diagnosis in 78%. That is 3/4. They had the same diagnosis the diagnosis went unchanged in 25%. In another 26%, the diagnosis was refined. Probably the classification, the subtype, something was refined. In 16%, it was not ILD at all. It was alternate diagnosis. Further evaluation before attaining a final diagnosis was reported in 32%, and the diagnosis entirely changed in 4%. So there is a serious business in getting to the right diagnosis. Then this slide talks about the treatment details. So these are patients who are posted on the MDT. On follow-up, there are treatment ambiguities. The PFT is not correlating with the imaging, vice versa, clinical. Do we need change in the treatment? So this is drug-wise treatment changes that were documented, and overall 60% were suggested some modification in the dose of one or more drugs in what the patient was taking. 40% were continued on the same. To summarize the outcomes from the ILD MDT, it's a gold standard for the diagnosis of IPF and many other ILDs. A dedicated team with expertise is required. It can be conducted, virtual, face-to-face, or hybrid. It enhances the accuracy of the diagnosis. It channels appropriate investigations and helps decision on disease progression and treatment. It is the background of a ILD specialist center who needs to provide good patient care. So to continue, you need to brainstorm, going back in your circumstance, the various components of a comprehensive ILD care, like diagnosis, multiple disciplines involved, ILD clinic, ILD MDT, pulmonary rehab, and so on. And if you do that and come up with a plan, then you can provide the best comprehensive care for your ILD patients given your circumstances. Thank you.
Thank you, Dr. Barney.